Great question. And there's actually a lot of things that are going on, and I'm really excited to talk about them. There's been a growing movement to do home-based care. So for these patients, if you can go into the home, meet them in their home or their community, develop a trusting relationship, you learn so much about them and about what's affecting their health. That you can bring back and actually develop a plan that's going to be effective in keeping them healthy, keeping them out of the hospital and the emergency department. So I'd say there are a number of things. You know, there's some programs are doing house calls. This is like independence at home, but again, home-based primary care. The ACOs that I know who are doing this think this is really one of the most effective things they're doing. And in fact, there's one ACO, it's out in the Midwest, that is exclusively focused on homebound patients, and so their whole model is home-based primary care. And they've been extremely successful. They've saved over $100 million over the last 3 years. So that's a really important area. But we can talk about other people going into the home. Community health workers. This is another area that I think we're seeing lots of interest in accountable care organizations. And so the community health workers are trying to build a relationship with people. Community health workers would generally be from their neighborhoods. They would sort of match in terms of race and ethnicity and culture. So they can talk to the patients oftentimes better than the medical professionals who may be not really understand their life situation. And these community healthcare programs are trying to do two things. One is they're really trying to understand and develop a relationship with the patient. The second thing they're trying to do is match them to social services, and the most effective programs actually help people sign up for local services. They don't just say, here's a phone number. They actually help them sign up. And then the third thing is to make a much better connection with the primary care team back home. And so patients get into the office when they need to. If they can't get into the office, they work out transportation, so they do get into the office. There are, one of the things we're going to be talking about at this conference are extensivist models. So an extensivist model, a lot of people know it from the CareMore system out in California, but the idea is you're identifying your highest risk patients. Typically these are maybe patients who are in the hospital and are going to be discharged out. And what they do is have a multidisciplinary team, and they follow the patient. So they may, the same doctor may round on the patient in the hospital. They may actually, if the patient goes to a nursing home, they'll round on the patient in the nursing home. They'll see them in the clinic, and they have a whole team that includes social workers, pharmacists, home health aides, a variety of things. So you're really trying to wrap care around these folks who are at high risk for landing back in the hospital or back in the nursing home, and trying to prevent that. And so we're having a session talking about those models today. There are post-discharge clinics. There is a new profession called sniffist, which are physicians that round with people round with their patients in the nursing home, and that's growing use in ACOs. More use of remote monitoring and telemedicine, and again, that's been proven very effective for patients in nursing homes, remote monitoring and telemedicine situations. And I even talked to an ACO recently. They're using community volunteers to go out into the community and again engage the patients, identify where people are socially isolated, talk to them about their problems, get them to come into the office. So a lot of creativity is needed to do a good job, and I think we're beginning to see a lot of creativity in this space, both in and outside of the ACO model.